Introduce Dr. Uzma Basit, who's going to be speaking to us about improving compliance of VTE prophylaxis patients admitted in the hospital. Now, Dr. Basit graduated from Karachi in Pakistan in 2019, and she joined Haldar Health Board in 2022. She worked in A&E for a year, and then she joined internal medicine in Haldar Health Board, working on a range of medical wards. Work in this department has led to her being actively involved in quality improvement projects involving audit and research. Most recently, she's been involved in teaching medical students and new junior doctors to support implementation of learning from the quality improvement projects. Uzma is now a clinical fellow in medicine working in the University Hospital of Wales in Cardiff. So if I can hand over to you, Uzma, and welcome.
Hello, thank you so much for the introduction. So I'm going to give this presentation on improving compliance of VTE prophylaxis patients admitted in the hospital. It was part of my quality improvement project, which I did in High-Wilda Health Board with the Bush Journal Hospital. So I'm going to start my presentation now. Next slide, please. So what is hospital-acquired thromboembolism or HAT? Hospital-acquired venous thromboembolism, also known as HAT, covers all VTE, occurs in hospital and within 90 days after a hospital admission. It is a common and potentially preventable problem. Next slide. Introduction. So 25% patient deaths occur annually due to VTE in UK. Critical care patient VTE risk is between 25% and 32%. Infection, inflammatory processes, vascular injury, and recent surgery, all of these factors, as well as immobility, they increase the risk of venous thromboembolism. Next slide, please. Venous thromboembolism remains a leading cause of preventable morbidity and mortality associated with hospitalization, despite evidence that providing appropriate thromboprophylaxis to those at risk of VTE in hospital. Recent data suggests that the delivery of thromboprophylaxis remains suboptimal across the globe, with a lack of standardization in approach to VTE prevention. This review considers the role of VTE risk assessment and interventions to improve the implementation of VTE prevention pathway and highlights the systemic approach to VTE risk assessment in line with always thromboprophylaxis policy. Dosing concentration. So we have to always make sure that we are writing the correct dose of VTE when we are prescribing VTE prophylaxis. For those patients who are having renal insufficiency, in 30% critical patients, we have to make sure that we are providing the we are writing the correct dose. Bioaccumulation of enoxaparin and manufacturers of enoxaparin, they recommend reduced dose in severe renal impairment, defined as creatinine clearance less than 30 ml per minute. And we have to make sure that we are weighing every patient before writing the dose of VTE prophylaxis. Suboptimal antifactor tunnel levels in opacity, we have to consider that. And those patients who are having low body weight, they are at increased risk of bleeding event. So what were the QI standards? Venous thromboembolism in over 16s, reducing the risk of hospital-acquired venous thrombosis or pulmonary embolism. According to the recent 2019 NICE guidelines, we have to reassess every patient who are at risk of bleeding and VT within 24 hours of admission and whenever the clinical situation changes. But according to the SIGN guidelines, we have to reassess every patient every 48 to 72 hours or sooner if condition changes. And people admitted to hospital, for all those medical patients, we have to identify the risk of VTE and bleeding as soon as after admission to hospital or by the time of the first consultant review. We have to use a tool which was published by a national UK body, professional network or peer-reviewed journal. A tool commonly used to develop a treatment plan for medical patients in the Department of Health and VTE risk assessment tool. I think it is present in every hospital. Every hospital has their own VT risk assessment, or we also say VT risk performer. Next slide. Thank you. Aims and objectives. So what were our aims and objectives? Aims and objectives was to reduce VT risk in hospitalized patients, to reduce the number of potentially preventable HAT cases. VT prophylaxis consists of pharmacological and non-pharmacological measures to reduce the risk of DVT as well as pulmonary embolism. Methodology. We work with the quality improvement team, junior doctors, and we utilize QI methodology. We completed PDSS cycles. We collected data from different medical patients admitted in Vidibhush Journal Hospital. In PDSS cycle 1, we provided posters in departments raising awareness of VT risk assessment. The risk assessment was placed within the clerking performer to be more visible to medics. In PDSS cycle 2, we communicated with the nurses, ensuring patients are wait in triage and ambulance areas so doctors can calculate creatinine clearance and the correct dose of VT prophylaxis highlighted on the risk assessment. In PDSS cycle 3, we delivered a teaching session to educate teams on the importance of VT prophylaxis and completion of VT risk assessments. So we placed these posters in different hospitals in different departments in Vidibhush Hospital. We placed those posters in A&E, in acute medicine, in frailty wards, in cardiology ward, and in different wards to raise the awareness about VT prophylaxis. So, what is the current HAT investigation process in Vidibhush Hospital, High Wilda Health Board? First of all, a QI department will send the reports to the radiology. Radiology will send the report to the IT department, and they're gonna filter the results within 90 days of admission, and then results will be sent back to QI department. Results will then be transferred to Excel and filtered for less than 24 hours admission. Investigation will be reviewed by clinical director or clinical lead. Each case being investigated by QI practitioner, and they will get the results. Then results will be sent to different sites. HAD deemed unavoidable. If HAD is deemed unavoidable or potentially preventable, then the report will be sent to the consultant or clinical lead. If nursing staff is also involved, we are going to send report to the ward manager. Then DATIX will be completed and duty of condor then triggered. So what were the factors why there was non-compliance of VT prophylaxis in Vidibhush Hospital? So basically in High Wilda Health Board, we have the paper system. We don't have electronic system. So we identified there was lack of documentation. Doctors, they were not compliant with their documentation. So what were the factors? Lack of justification in medical notes, incorrect prescription dosing, no documentation on drug chart, lack of justification in nursing notes as well. And they were prescribing wrong dose of VTE on drug chart, unsigned doses. VT risk assessment was not completed. Delay in prescribing VT prophylaxis, which can also cause VTE, and no clear place where to file VT risk assessment, lack of knowledge of risk assessment content, lack of staff engagement, and lack of awareness about the documentation. So all of these combined factors lead to number of potentially preventable HAD cases. So what were the common themes? Missed dose, unsigned dose of thromboprophylaxis, incorrect dose of thromboprophylaxis prescribed because they were not able to weigh the patient, and that's why they were not able to calculate creatinine clearance, delay in prescribing thromboprophylaxis, VT risk assessment not completed. So this is the driver diagram. There were primary drivers as well as secondary drivers. So what were the primary drivers? High standard of documentation for VT prescribing, robust process for assessing for VT and prescribing thromboprophylaxis and reviewing cases. Workforce with confidence, knowledge, and willingness. I'm gonna only tell only few secondary drivers which were really important. So secondary drivers were like ensure all rationale for non-prescribing or administration of thromboprophylaxis is documented. All patients who require thromboprophylaxis have it prescribed within 14 hours of admission and documented in correct place on the drug chart. All patients who have VT risk assessment completed within 14 hours of admission. Clear process for filing of VT risk assessment. Timely review of HAT cases. All clinical staff to be aware where risk assessment is in the what. Clinical leads to have their awareness about HAT cases, and clinical staff have education on the importance of VT risk assessment and prescribing. Next slide, please. So our stakeholders were consultant, junior doctors, ward managers, QI practitioner, and ward staff. We were communicating with them regularly, weekly or after every 2 weeks, and we were updating them about our QI projects, and we were making sure that our ward managers were satisfied with what we were doing. Next slide, please. So what were the results? The data demonstrated improvement following PDSS cycle 1. At PDSS cycle 3, there was a median step change from 30% to 70% compliance. When we started our PDSS cycle 1, we also did an audit on quality improvement. We also did an audit on VT prophylaxis. And we found out that there was only 30% compliance. But after our PDSS cycle 3, there was a gradual improvement, and we had 71% improvement after our PDSS cycle 3. There were no cases to investigate for HAT during that period. The improvement is currently sustained. Process measure. So after our 3 PDSS cycle, as we can see, when we started collecting data from day 1 and till day 20, there was almost 80% improvement, and doctors were very compliant in the prescribing VT prophylaxis, and they were also making sure that they are completing VT risk assessment. Next slide, please. And yeah, and this is when we collected data, and we were not sorry, this was a percentage of patients who had VT prescribed, whether they had VT risk assessment present or not. And there was 100% improvement at one time. So what was an outcome measure? After January 24, there were 0 cases to investigate in Vidi Bush Journal Hospital. So we were quite happy that there were no cases to investigate for HAT in Vidi Bush Journal Hospital, because we were really working hard and we were making sure that doctors are prescribing VT prophylaxis. So these were the results. In PDSS cycle 1, we had 75% improvement. In PDSS cycle 2 and PDSS cycle 3, we had 70% improvement. Conclusion. In a hospital setting, VT is common but preventable. VT risk has to be assessed and where indicated, prophylaxis to be initiated. Thank you. Any questions?